Hi everyone. Today we're going to have a conversation with Dr. Wolff. She's founder of Pelex Fertility. It's a fertility platform. And she also is the Chief Medical Officer for Mosie Baby. Hi everyone. We'll get her on here in just a second. We'll let everybody hop on. Hello, hello. Let me see if I can get Dr. Wolff on. Hold on one second. Dr. Wolff, if you want to add yourself, please do. Hi. Just to confirm, she needs to add, right?
Yeah.
Okay, yeah. Yeah, so you'll need to, there we go. She requested. Awesome. Okay. Dr. Wolff is going to hop on here in just a second. Let's see. There we go. Hi.
Good to see you.
How are you? Good to see you too. Sorry. Trying to figure this out. So happy to have everybody joining in. Feel free to put questions as we're going along. We'll try to get to them. We're gonna have a little conversation first and then we'll get to them towards the end. But first I want to introduce Dr. Wolff, who is an incredible doctor. She has started, she's also an entrepreneur. She launched Pelex Fertility and she founded that after being an esteemed researcher with NIH. And she was a researcher for, I don't know, over 8 years. And then went on to found her own practice. She's been working virtually with people and in clinic. So she's really gotten to understand the needs of people who are trying to conceive and where they might be at in their journey. Obviously, there's a lot that can go into that, and sometimes logistics is a part of that. So Dr. Wolff is really great at working with people where they're at. And she also is the Chief Medical Officer for Mosie Baby. And might I add, this is her first Instagram Live, and we are super happy to do it with her. So we are going to have a great conversation. And like I said, if you have some questions, we'll try and collect them and answer as many as we can at the end. But first, Dr. Wolff, I'd love you to just do your own little intro, make sure I said everything accurately. Yeah. Feel free to correct me if I got anything wrong, and then tell us a little bit about your practice.
Yeah, no, that's exactly right. So I started Pelex, and we started as actually before the pandemic as concierge medicine, and then after the pandemic became telemedicine, and then have now layered on our first brick and mortar practice in Lubbock, Texas. And I'm so excited to be here today to talk to everyone about Mosie. And as you mentioned, for the past 6 years, up until May, I only had the option to help patients through telemedicine. So it definitely gave me a window into a whole portion of the reproductive journey that I almost never saw when I was just dealing with patients in fertility clinics. So I'm excited to talk more about that with everyone.
Awesome. So the first question I have, though, I think you can help us with, which is just explain to everybody, what is a fertility specialist? What is a reproductive endocrinologist? Yeah. And, you know, like, how can people understand that type of medicine and that type of focus?
Yeah, sure. So I'm an OBGYN. So first you do 4 years of residency in obstetrics and gynecology. And then you do 3 years of fellowship subspecialty training in reproductive endocrinology and infertility. So there's 2 parts of our training. One is the reproductive endocrinology, and that's endocrinology is hormones. So we specialize in hormones that deal with or impact reproduction. And then also the infertility is what a lot of us focus most of our time doing IVF and treatments. So sometimes it's really hard to be able to get to see a reproductive endocrinologist if you're not trying to get pregnant, because it's so hard to get into fertility clinics these days.
Yeah. So at what point should someone consider seeing a fertility doctor, a fertility specialist like yourself? Where in their journey should they say, you know what, maybe it's time for me to call somebody?
Great question. So the society guidelines say that you kind of have to sit at home and fail for 12 months to get pregnant. And that's 12 months of disappointment and then heartbreak and negative pregnancy tests. And I think it's really a disservice to women and families and people to wait if there's a correctable issue. So a lot of what I believe in and work in and on is that if you treat the underlying health conditions, it's good not just for fertility, but it's good for overall health. So ideally, everyone would be able to see a reproductive endocrinologist if they have any abnormality in their menstrual cycle or any concern. And also, it would be great if our societies told our generalist partners that we should be checking an AMH value every year at your pap smear or when you go in for your annual exam, because it can pick up like some important conditions that affect, again, not just baby making, but your health.
Yeah. One of the things that I feel like is really relatable that I experienced, that so many people experience, when you don't get pregnant right away, like, you know, in those first 3 months, you're like, woo, we're gonna get pregnant any day now. And then all of a sudden you're like, okay. And then you start going down that path, and that takes you to a whole bunch of mental places and physical places. And I think for me, which was this realization that what you just said is your fertility, your period, your menstrual cycle actually is a really good reflection of your overall health.
Definitely.
And so when you look at the structure of how medicine is and the way we separate that, and we separate out, you know, the vagina essentially, and the uterus and the fallopian tubes and all that whole all the reproductive organs, as in it's like this own isolated thing in the body that the rest of general medicine is like, oh, well, you know, I find that, you know, like so many people, it was flooring to me to realize that we hadn't been educated on the value of our menstrual cycle, and that you have this relationship to your hormones, which are related to every other part of your body. And so it's really something that I feel like when you go to reproductive endocrinologists like yourself, you almost have to, like you said, take a step back and evaluate the whole system, because the hormones are in this like orchestration and they're all connected. And so isolating, which often is done per, you know, the desired results, right? Like you kind of isolate those hormones, but in the end, the whole system is connected. So I like that you take that approach, and that you are very whole body minded in the way that you evaluate people. But I'd love to understand, what are some of the challenges patients come to you with, and, you know, common or uncommon, if there's anything that comes to mind that you'd like to share with everybody joining.
Yeah, so there's kind of 3 buckets. It's sort of egg problems, uterus problems, and sperm problems. And then unfortunately, about 10% of couples, it's a kind of a double-edged sword. Their testing's all normal, but they still have unexplained infertility, which can kind of sometimes be even harder than if you know what's wrong. So it can be problems with endometriosis. A third of all couples are affected by male factor infertility. And a lot of couples have a combination of one or more of those things.
Yeah. So what are some of the gaps in patient care that you see in your practice or industry-wide?
Delay in treatment is a huge one, because success rates go down. So the sooner you can try to get pregnant, the sooner you can try to have an evaluation, the sooner you can get tested, find out if there are any problems that would, you know, prevent infertility. Or if you know that you have anovulation and you're not releasing an egg, then you shouldn't wait for 12 months. Or if there's a male factor, then you should go straight too. So that's a big thing. A second big thing is coverage for fertility services. It's still not covered in, or there is not mandated coverage in most states, which is another barrier. So that makes it really impossible for many Americans to access care.
Yeah. Yeah, cost is a huge factor for a lot of people. Time delays, getting you know, to the appropriate doctors. So it looks like we have some questions coming in, so we'll get to those in just a second. Love to understand, you know, as we talk about Mosie, you know, our indications are for people who are ovulating. Obviously that's important. If you're doing anything at home, you need to be able to confirm ovulation. And then, you know, there's people who find themselves either tired of sex, with maybe some performance issues or just connection issues, maybe some painful intercourse. There's a number of people who come to us, but I'd love for you to kind of help people understand, when is home insemination a fit for patients that you see? When is it a fit for them to work with their doctor? Or, you know, if you can elaborate on like how people can kind of think through using the Mosie Baby kit for home insemination versus, obviously there's big differences about what's done through IVF and other in-clinic procedures.
Yeah, and I would, again, when I was only in a clinic and offering IUIs, I almost never asked about issues with intercourse because I wasn't going to be prescribing intercourse and I was going to be skipping that part. And when I was doing telemedicine only, it definitely was eye-opening how many couples struggle with that. So couples that struggle with timed intercourse, or it becomes a burden, or it is adversely affecting the relationship to have to try just for conception, I think Mosie Baby is a game changer, that they'd be able to use that. And again, and then also the indications that you mentioned, like if there's pain with intercourse, yeah, those are some of the biggest ones that come to mind.
Yeah. So let's answer some of these questions. Okay. You know, I did see one just come through about the length of Mosie. So actually the length on Mosie Baby is very thoughtfully designed. So Mosie has a longer, wider spray. And with that, you want to make sure that as well, even without having that longer, wider spray, we have the handles, which are the optimal length to insert up to the handles to guide you. Because anything longer, you risk bypassing the cervix and just aiming at the vaginal wall. So Mosie is designed to be that length on purpose. And so I know some people are like, well, that's, I mean, if you look at it, it's not, you know, incredibly long. And that's actually because you don't need something incredibly long. Most people can reach their cervix with their middle finger. And when you think about it, your middle finger is not about, you know, 8 inches long. So you are okay with this length. That's a question we get sometimes. Okay, a question came in. Does working out too much inhibit conception?
There are a subset of patients, particularly athletes, female athletes, that work out and use a lot of calories and their nutritional intake isn't meeting those requirements. It's a pretty common phenomenon that the brain will shut off ovulation and having periods. So if you're an athlete and you're not getting your period, then that is an important sign to talk to a doctor and a reproductive endocrinologist to try and help get your period back, because you're at risk for fractures due to low estrogen. So yes, if you exercise too much, it can impact infertility, but it doesn't impact everyone. Some people are very resistant to shutting off their ovulation, and some people are very sensitive.
Yeah. So does having a tilted uterus matter?
Good question. So sometimes it's just an observation when we're doing an ultrasound. We're like, oh, that's tilted forward. Okay. But what it sometimes can signify is if it's tilted backwards, it can be a soft sign of endometriosis. So it's a sign that there's scarring in the pelvis that's pulling the top of the uterus backwards and scarring it in place.
Yeah, so one of the things that we have heard is this question about tilted uterus. And I've talked to a couple of medical professionals about this as well. And one actually shared some really good insight. And she said, you know, I feel like we shouldn't necessarily always say that to people, because some people, it's great information. They're good, you know, they're good to go. Other people sometimes internalize it and start to get really worried about conception or how it's going to affect things, or maybe their sex life. So it's good to hear that, you know, it's typically, you know, this can happen, but to understand that if it is tilted pretty far backwards, I guess towards, to be anatomically correct, the anus, is that where you're thinking?
Or the spine. The spine.
Okay. Yeah. So that would be a question for you if you have a tilted uterus, to kind of understand the tilt of it. But it's fairly common, so it's not something that will inhibit conception. Okay, so how you want to? Why don't we talk about the tests done? There's a question or two about tests done to prepare for an IUI. If you want to walk us through that process.
So the workup that you would need before you get your IUI would include blood tests to look at ovarian reserves, such as day 3 FSH and AMH, and an ultrasound to look at the antral follicle count, which is how many small resting follicles there are in the ovaries. And then we do prenatal labs. Instead of waiting until you're pregnant and walking in the door at your OB, we do it beforehand because you can get boosters for viruses that can cause congenital birth defects in pregnancy, so we can get you immunized before pregnancy, and check a semen analysis to make sure that there is enough sperm to make IUI acceptable or a good option or not futile.
Yeah, so this is a good point, actually, that one of the things that we've seen, and you've done this and a couple of other doctors have done this as well, is there have been some patients where it was a best first step that you have identified for them to utilize Mosie, even having gone through the workup. So I think that's something that's good for people to understand. I don't know if you can share how you've done that, especially because some people geographically, it's difficult for them to get to locations. Mm-hmm. If you could speak to that for a second.
Yeah. So I'm thinking of some patients that are kind of in remote areas that in like the mid-southern Atlantic region, and husbands maybe that have diabetes, problems with erectile dysfunction, travel schedules, you know, or other patients that have been trying every month, and it's the husbands aren't able to try around the time of conception. So those patients have gotten pregnant with Mosie. So
yeah, that's very cool. Well, okay, we have a whole bunch of questions. We'll try and get through these. So one that came through that we do get, which is a question around sperm count. So when is somebody typically referred to IUI for sperm count issues, and what is kind of the range that IUI is good for that?
So one part of our IUI classic population is unexplained infertility, and all their sperm counts are exactly normal, and the females testing is as well. And then another bucket is sort of mild male factor, but not severe. So sometimes we think that an IUI might be able to help couples with some mild male factor infertility. And so we used to use one of the measures is a total motile sperm count. So you take the volume times it by the concentration and divide it by the percent that are swimming normally. And we used to say about 10 million is an IUI worthy sample, but there are some data that you can go down to like 5, but the pregnancy rates do start to drop off a little bit until 5 and then more after that. And then the other criteria is morphology. Morphology is a tricky parameter on the semen analysis. It's hard. You have to be very vigilant for the labs that report morphology to stay in a quality controlled range, because it's easy for people to kind of become more and more strict in their numbers. You know, they start with, you know, this many people usually get this number, and all of a sudden everyone's getting 1%. But if it's a true 1% morphology, then that's in and of itself a reason to proceed directly to IVF with ICSI. Yeah. So it's kind of two separate things. It's the morphology independently, but also the total motile sperm count.
Yes. So we've got a lot of questions coming through. If we don't get to all of them, we'll try and message you guys directly. A question that we've had, so going back, I have 2 questions that I want to make sure we get to. One is around when you recommend people do their first insemination and their second insemination. Mosie comes with 2 insemination attempts per kit. And then also, just briefly, we've been talking about IUI, but I don't think we defined it. And so somebody asked, what is IUI? And of course, that's a great question to ask. Yeah. So if you wouldn't mind sharing.
Sure. So IUI is intrauterine insemination, and you can't take raw, like just fresh semen sample and put it into the uterus, because it has prostaglandins that would cause intense cramping of the uterus. So we have to wash it to get rid of some of the seminal fluid and purify only the swimming and healthy sperm. And then we put the tiny flexible catheter through the cervix into the other side, which is where the endometrial cavity and uterine cavity is, and then insert the sperm there.
Yes. And So when you're working with your patients to use Mosie, how do you, when do you tell them to use their first syringe and then their second syringe?
So one of the reasons that I think Mosie is to fertility docs could be slightly shockingly effective, and that the pregnancy rates are so high, is because when we prep the sperm and clean it out with that process that I just mentioned, it activates all the sperm at one time, and they only live for 24 hours. So for IUI, you have to be very specific about when to trigger ovulation and when exactly to do IUI. And there's good data that you only need one IUI and two are not better. So for Mosie Baby, the sperm are going to be able to be more natural, and they're not going to all get hyperactivated. So if with intercourse, normally there's the sperm slowly go up the reproductive tract. They can sit in the cervical crypts for up to 7 days and lead to pregnancy 7 days before ovulation. So for Mosie, I like to recommend 3 or 4 days before ovulation, and then again with the ovulation. So you have sperm ready and sitting there for when ovulation happens, and then you have a nice window of abstinence to let the concentration build back up and have another great sample.
Awesome. So we did have a question about endometriosis. How does endometriosis affect fertility, and what do you suggest to overcome it?
Endometriosis is nasty. It kind of takes a tax. I kind of describe it as taking a tax at every step of the way. A little bit lower ovarian reserve, a little bit. So if you do IVF, you have a little bit a lower response to medication, a little bit fewer than average eggs, a little bit fewer than average fertilization, a little bit worse embryo development. So it's just kind of like an uphill battle all the way. We often don't recommend doing medications at home like ovulation induction, like Clomid or letrozole, because our worry is that we would make all these ovulations that could become endometriomas, which are chocolate cysts of the ovary. And when those happen, they're like basically a big scab in the ovary, and they cause a lot of inflammation. The ovary doesn't work as well when we try and do fertility treatment later on. Endometriosis can cause pain and infertility, but there's lots of really fertile women with endometriosis that it doesn't cause any infertility. Mm-hmm. So it's a very difficult disease to understand and know exactly how to treat. But
yeah, I feel like what you said about endometriosis, I feel like that's so relevant to a lot of fertility. Is, you can have like you were talking about exercise. The person who asked about, can you exercise too much? Some people can see their cycle go to the wayside. Other people, it doesn't affect them. Endometriosis, you can still be fertile, or you may have severe issues. A lot of what happens, I feel like, with fertility is it is so individualized. And so that's why we always, recommend with Mosie, if you're not seeing success for 3 to 6 cycles, we definitely want you to get checked out. We also want to make sure you're ovulating prior to use and that you understand how to use the product. So we did have a quick question or two about using Mosie. So one of the questions was, how do we feel about using Mosie with frozen sperm 1 day before peak? So frozen sperm, obviously you really want to target your insemination, because people have invested in logistics and timing and cost to make sure they're timing everything properly. So do you have any insight or suggestions around that?
Yeah, it can get kind of tricky if you're doing it at home to figure out how to do all that timing. But when you're in a clinic, or if a telemedicine doc's helping you at home with a trigger, if you don't have your own LH surge already and we make you surge, then it's about 36 hours, and that's when you want to do the insemination. And hopefully the egg is around, getting ready to be out, and then the sperm is there within a few seconds and can be there for 24 hours.
So you recommend, when you're doing like a trigger shot for ovulation. So for people who don't understand that, can you explain what that is real quick?
Oh, sure.
That, process real quick. Yeah.
Yeah. So the trigger shot is an injection that we give to mimic the LH surge. And it's with pregnancy hormone, ironically, HCG. but it's structurally very similar to LH. LH leaves your system very quickly, and HCG stays around much longer. But that's one of the ways that when an early pregnancy starts secreting HCG, that it stimulates the corpus luteum to prevent you from having a miscarriage. So it's not totally not coincidental that they're similar in structure. So yeah, so if we give you a fake LH surge and do it ourselves, and you didn't have any yourself, then it takes a while to get into your system, and then a while for your ovary to respond. So you have to give time for both of those things to happen. When you have your own natural LH surge, it happens, it's been in your system for a while, it has to come out in your urine, and then you test and you finally find it. So you kind of have already had it in your system for a while. So then you want to time it for about 12 hours later.
Okay, so we have 2 more questions that we'll get to, and then anybody else who we did not get to your questions, we're going to try and answer them directly, or shoot us a DM. So a question about any adjustments. So if somebody has a retroverted uterus, any adjustments for using Mosie that you would think through?
I wouldn't, because we're again using more of the natural approach, and so women get pregnant with a retroverted uterus, and the sperm is able to swim. So the sperm is going to sit in the vagina initially. It's going to, parts of it over time will travel to the cervix, parts of it will stay there, and then over time travel into the uterus and then into the fallopian tubes. So no adjustments. The sperm have to do a lot more work regardless of which way the uterus is tilted.
Yeah. And then how do you feel about fertility vitamins? There were kind of 2 questions about vitamins. So that was one. And then the other one is, can folic acid cause headaches?
So folic acid is the most important vitamin, and it's important to start it before you conceive, because what it does is it prevents spina bifida, or neural tube defects, and it's often before anyone knows they're pregnant. So that's why if you're thinking about getting pregnant, or have a chance of getting pregnant, to be on it.
Mm-hmm.
That's the most important one. Prenatal vitamins in general, just to have an over-the-counter, is fine. To have enough iron to start getting your blood to be primed to be able to make more blood as your blood volume expands in preparation for pregnancy. And those are the most important ones.
Well, thank you so much. You made it.
Thanks for having me.
Great on your first ID Lab. I'm so honored to be here with you, and it's good to see you. Thank you, everyone, for joining in, and we appreciate your questions. We had so many, and it was really great to have the chance to answer those questions with you, Dr. Wolff. So thank you again.
Thanks for having me.
All right. Take care. Bye.
Bye, everyone.
Okay.